The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/EMM860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Karen Anderson from Georgetown University School of Medicine in Washington, D.C. Welcome to this case-based activity on finding the path to improved recognition and management of tardive dyskinesia. This program is designed to aid in recognition of tardive dyskinesia and its treatment. As part of this activity, we will review the causes and symptoms of tardive dyskinesia, discuss the impact of tardive dyskinesia on patients, review the diagnostic process for tardive dyskinesia, and examine the role of VMAT2 inhibitors in the management of tardive dyskinesia. Clinical presentations of tardive dyskinesia are quite varied. They are involuntary, repetitive, purposeless orofacial movements. Patients can also experience contraction, twisting, or writhing movements of the fingers, hands, arms, or legs. Orofacial features of tardive dyskinesia are probably most familiar to many clinicians. These include lip smacking and puckering, puffing of the cheeks, grimacing, and tongue protrusion. This can have a functional impact on speaking, chewing, and swallowing, and can cause social embarrassment, which adds to the burden of chronic mental illness. However, there are also whole body features of tardive dyskinesia that may not be as commonly recognized by clinicians. These include chorioathetoid movements of the fingers, hands, and extremities, axial symptoms such as neck and shoulder movement, spine movement, and pelvic thrusting. Factors associated with a high risk of tardive dyskinesia development include current or recent treatment with a first-generation antipsychotic, older age, longer cumulative exposure to antipsychotics, and presence of acute extrapyramidal symptoms other than acute akathisia, including Parkinsonism. In terms of pathophysiology, we think that the presence of dopamine-blocking agents in the postsynaptic receptor neuron causes the neuron to adapt by upregulating the dopamine D2 receptors. This increases both the number and the function of D2 receptors. This upregulation of dopamine D2 receptors results in a hypersensitive or supersensitive state. If this occurs in the dorsal striatum, it can lead to hyperkinetic or fast movements of tardive dyskinesia. The prevalence of tardive dyskinesia among individuals treated with antipsychotic agents has been studied in several meta-analyses. First-generation antipsychotics, the older group, tend to have a prevalence of about 30%. Second-generation antipsychotics, 20.7 or 21%. Management of tardive dyskinesia involves several steps. The first is always to try to discontinue medication when possible. Obviously, this is very difficult in chronic psychiatric patients who may have achieved stability after many, many years of treatment trial and error. The second strategy is to switch to a less potent dopamine antagonist. Again, this might be possible, but it might cause a relapse of the underlying psychiatric symptoms. And then a third is to add an adjunctive therapy. There are AAN evidence-based guidelines on the treatment of tardive dyskinesia symptoms, and these data are at this point insufficient to support or refute withdrawing the causative agents or switching from typical to atypical dopamine receptor blocking agents. The possible modification of antipsychotic and anticholinergic regimens is supported by expert consensus, however. VMAT2 inhibitors are used to treat tardive dyskinesia if the strategies of stopping or reducing or switching dopamine blocking agents is not successful. VMAT2 inhibitors can decrease dopamine release to treat tardive dyskinesia. Blocking VMAT2 inhibits dopamine transfer from the cytoplasm to vesicles, so less dopamine is ultimately released. VMAT2 inhibition provides an enduring method of decreasing dopamine neurotransmission in a supersensitive or hypersensitive postsynaptic neuron. And VMAT inhibitors are recommended as a first-line adjunctive pharmacotherapy for tardive dyskinesia. Today we're going to be discussing the case of Kay. She's a 52-year-old woman who works as a cashier in a large retail store. She's also a professional singer. She's struggled with bipolar disorder for over 20 years and has settled on a stable medication regimen of carbamazepine and haloperidol. In the remaining program segments, you'll have the opportunity to select case scenarios by choosing decision points and patient considerations that will cover different aspects of the diagnosis and treatment of tardive dyskinesia. In this case, we're going to discuss tardive dyskinesia screening and assessment. A special consideration is noticeable changes in movement symptoms. Kay is a 52-year-old woman who works as a cashier at a retail store and is also a professional singer. She's had bipolar disorder for over 20 years, takes carbamazepine 500 milligrams twice daily for the last 15 years, and haloperidol 5 milligrams twice daily for the last 5 years. She reports muscle spasms in the neck and nape area. She was aware of it, but thought it was just a tic or spasm, or that others didn't notice it. But now she's seeking help because someone asked her about it. They noticed it when she was performing on stage, so other people do notice these symptoms. Screening for tardive dyskinesia is very important. Any patient taking a dopamine receptor blocking agent should be screened at every clinical encounter, asking about abnormal movements or if others have asked them about abnormal movements. It should also be followed by routine semi-structured assessment, including review of abnormal movements, visual observation by the clinician, checking with caregivers to see if they notice abnormal movements, and then patient reports, and also effects on function and quality of life. So does the patient have trouble eating? Do they feel that other people are noticing the movements and perhaps ridiculing or avoiding them? And then less frequently, it's recommended to conduct a structured assessment such as the Abnormal Involuntary Movement Scale, or AIMS. The AIMS is a scale that was designed to quantify the amount and also the effects of abnormal involuntary movements. Items 1 to 7 give a score based on the observed movements in the patient. Item 8 gives an overall severity index. Then there are additional items that provide information that might be useful in clinical decision-making, and then there are yes-no questions concerning whether patients have problems with their teeth, whether they're wearing dentures, and how their sleep might be affected. Diagnosis of tardive dyskinesia is based on the following criteria: the presence of involuntary movements, either during exposure or after exposure withdrawal from antipsychotic or other dopamine blocking agents. There's a differential diagnosis for the movements that we'll discuss, the patient history of how the movements began and whether they've changed in any way, a history of the cumulative exposure to antipsychotic medications, doses, types of antipsychotic medications, the current medication regimen, and the duration and severity of the abnormal involuntary movements. You should consider a neurological consultation if the patient has a particularly atypical presentation, perhaps the movements don't look like tardive dyskinesia, or the course is unusual, for example, very rapid fluctuation or change. If the patient has a family history of other neurodegenerative disorders that can cause abnormal movements, that might indicate the presence of a genetic condition, presence of other signs and symptoms, uncertainty as to whether this actually is tardive dyskinesia, or an unexpected treatment response. In terms of differential diagnosis, some of the more common conditions to consider are akathisia, drug-induced Parkinsonism or tremor, edentulous dyskinesia in patients who have dental issues or completely missing teeth, spontaneous dyskinesia, drug-induced dyskinesia caused by other agents, and chronic motor tics. Some of the less common things to consider are autism with stereotypies, blepharospasm, Huntington's disease, Mage syndrome, psychotic stereotypies, restless leg syndrome, senile chorea, Sydenham chorea, Tourette syndrome, Wilson disease, and Rett syndrome. A couple of key points to keep in mind. You should screen all patients who are taking dopamine receptor blocking agents at every clinical encounter. Use semi-structured assessments and periodically use the Ames scale that I mentioned. And consider diagnostic criteria and differential diagnosis. Now we'll go back to our patient and discuss tardive dyskinesia screening and assessment. An additional consideration is a patient who's reluctant to use more medication. Kay is a 52-year-old woman. She's a cashier at a large retail store, and as we discussed before, she's also a professional singer. She's had bipolar disorder for over 20 years. She takes carbamazepine and haloperidol. Her initial exam showed spasms in her neck and nape area, and this led to the diagnosis of tardive dyskinesia. Kay is really opposed to taking more medications. It's important to be aware of the impact that tardive dyskinesia has on patients' function and quality of life when discussing treatment of the symptoms. Some individuals may not be aware of the symptoms, but it should not be assumed that that is always the case. Even people with fairly severe psychotic disorders may be aware of the symptoms causing pain, or that others treat them differently because of the appearance of the symptoms of TD. Even mild TD symptoms may be very bothersome or disruptive. For example, in the case of Kay, where she's in the public eye in both of her jobs. More individuals may be affected as second-generation antipsychotics are used for more indications, for example, as adjunctive therapy in depression or off-label for insomnia or anxiety. In a recent study of people with involuntary movements due to tardive dyskinesia, 40% reported the movements had some or a lot of impact on their usual activities, for example, talking. 75% reported feeling self-conscious or embarrassed due to the movements. So with a patient like Kay, you want to discuss tardive dyskinesia risk and management. We want to consider the risk factors: older age, use of first-generation antipsychotics, high-dose or very long-term dopamine receptor blocking agent use. We want to prevent persistent, irreversible tardive dyskinesia. So we want to really consider before starting any dopamine receptor blocking agent whether this is the best treatment or whether there are alternatives to this particular treatment for this patient. And then there are treatment options that are available for people who have developed tardive dyskinesia. This includes modification of the treatment regimen, so reducing or stopping or switching dopamine receptor blocking agents if that's possible, or adding a VMAT2 inhibitor to treat the tardive dyskinesia. Some key points to remember here. Avoid antipsychotics and other dopamine receptor blocking agents unless they're necessary. Limit your off-label use. Ask your patients with tardive dyskinesia about the impact it has on their ability to function, their quality of life, and their interactions with other people. Educate patients regarding the consequences of not treating tardive dyskinesia, treatment options for tardive dyskinesia. The best ally you can have is a patient who understands what TD is and can report it to you very early when it starts to occur so that you have a chance to really jump on it and treat it early. Now we'll go back to our case and discuss regimen adjustment. An additional consideration here is a noticeable change in movement symptoms. As you recall, Kay is a 52-year-old woman who's a cashier at a large retail store and also a professional singer. She's had bipolar disorder for over 20 years, takes carbamazepine and haloperidol. Her initial tardive dyskinesia symptom was spasms in the nape of her neck. Now the TD symptoms have worsened to include lip puckering and jaw movements, which are very noticeable when she's performing. The patient now says she would consider a treatment adjustment because these symptoms are so bothersome. We're going to discuss the use of adjunctive therapies for tardive dyskinesia with use of antipsychotics for approved indications. So these are patients who are taking antipsychotics often for chronic, lifelong disorders, who will need to be on antipsychotics for many years, if not for their entire adult lives. So certainly the first step is the patient or the clinician identifying symptoms of TD. They may be non-troublesome, so they may start off, as they did with Kay, with tics or small movements that the patient notices a bit, but they don't trouble her enough that she wants to take another medication. At this point, it's appropriate to have a discussion of determining the lowest effective dosage of her medications that she could take to reduce the antipsychotic burden and possibly lessen the tardive dyskinesia symptoms. If this leads to improvement, then we would monitor and follow up with the patient. However, if the symptoms are troublesome, again, we would determine the lowest effective dose of effective antipsychotic medication that the patient can take for her chronic psychiatric symptoms. If the tardive dyskinesia symptoms are improved but still troublesome or do not improve at all, we then may consider the addition of a suppressive agent. Agents that are approved for treatment of tardive dyskinesia are the VMAT2 inhibitors. Other agents that can be considered but are not approved include clonazepam or ginkgo biloba and amantadine. GPI-DBS has also been studied but is not approved. For patients who are using antipsychotic for non-approved indications, the path is similar. You want to evaluate the dosage and determine how troublesome the tardive dyskinesia symptoms are to the patient. You'd have a review by a specialist to identify whether there are alternatives to antipsychotic medication that could be helpful. Perhaps a patient who's taking an antipsychotic for insomnia could be switched to a different agent. If this leads to improvement, then you'd have close observation and regular follow-up to see if TD recurs or worsens. However, if the symptoms do not improve or if they're still troublesome, you'd then consider adding a suppressive agent. The sequence of this would be the same as in the prior case. The VMAT2 inhibitors are approved for treatment of tardive dyskinesia. Clonazepam or ginkgo biloba could be considered but are not approved. Amantadine is a possibility but would be off-label. DBS has been studied for this, again in the GPI, but is not approved. Key points to remember are using the lowest effective dose of a dopamine receptor blocking agent for any indication or off-label use. Monitor your patients frequently, before you've added a dopamine receptor blocking agent and after, for uncontrolled movements that could be tardive dyskinesia. There are adjunct medications that are available to reduce uncontrolled movements due to tardive dyskinesia. Now we'll go back to our patient to discuss regimen adjustment. An additional consideration is a patient who's reluctant to use more medications. Kay is a 52-year-old woman who's a cashier at a large retail store and a professional singer. She's had bipolar disorder for many years, takes carbamazepine and haloperidol. Her initial TD symptom was a spasm in the nape area of her neck. Her current treatments were adjusted to avoid use of more medications based on patient concern, which included safety and possible side effects of adding more medication. Now the TD symptoms have worsened to include lip puckering and jaw movements. Kay is still very reluctant to add additional medications. FDA-approved medications for tardive dyskinesia are the VMAT2 inhibitors. There are two of these medications, Valbenazine and Deutetrabenazine. In terms of dosing frequency, Valbenazine is once a day with an initial dose of 40 milligrams that can be increased to 80 milligrams in most patients. It can be given with or without food. It does have CYP2D6 and CYP3A4 action. Contraindications include MAOIs and hypersensitivity to valbenazine. Warnings and precautions include impairment in driving, somnolence, possible QTc prolongation, and Parkinsonism. Common adverse side effects include somnolence. Deutetrabenazine is given twice daily. The initial dose is 12 milligrams a day divided, and the recommended dose is anywhere from 12 to 48 milligrams a day in divided dose, so there is a different dosing range for individual patients. It can be given with food. In fact, it should be given with food. It has CYP2D6 action. Contraindications include MAOIs, valbenazine, reserpine, tetrabenazine, and hepatic impairment. Warnings or precautions for patients are impaired driving, somnolence, possible QTc prolongation, Parkinsonism, and neuroleptic malignant syndrome. Common adverse events include nasopharyngitis and insomnia. We have very good safety data from the long-term trials of both valbenazine and deutetrabenazine. In terms of AEs for valbenazine, any AE occurred in about 70% of patients. AEs leading to discontinuation occurred in about 16% of patients, serious AEs in about 14%, suicidal ideation in 5%, and AEs with an incidence of greater than 5% were headache, UTI, diarrhea, and dizziness. With deutetrabenazine, any AE was in 67%, AEs leading to discontinuation in 7.6%, serious AEs in 13.1%, suicidal ideation in 5%, and AEs with an incidence greater than 5% included headaches, UTIs, somnolence, depression, anxiety, diarrhea, and nasopharyngitis. A key point is to educate your patients regarding the safety of treatment options. Kay was reluctant to add more medications. She had concerns about increased pill burden and also about potential side effects. It's important to have discussions with patients, perhaps at several visits, so they understand the risks and the benefits of adding an adjunctive treatment for tardive dyskinesia. Now we'll go back to our case scenario to discuss VMAT2 inhibitor treatment. An additional point to consider here is noticeable changes in movement symptoms. As you recall, Kay is a 52-year-old woman who's a cashier at a large retail store and also a professional singer. She's had bipolar disorder for 20 years, takes carbamazepine, haloperidol, and now a VMAT2 inhibitor has been added. The initial diagnosis of tardive dyskinesia was made based on spasms in her neck area. The TD symptoms then worsened to include lip puckering and jaw movements that impaired her daily function. Carbamazepine and haloperidol were tapered and the symptoms worsened. Now a VMAT2 inhibitor has been added to treat tardive dyskinesia symptoms. We have long-term safety and efficacy data on both valbenazine and deutetrabenazine. With valbenazine, we have 52-week data showing efficacy in suppression of tardive dyskinesia compared to placebo. We also have data showing that during a washout period, the TD symptoms do rebound back to about the level they were at baseline. So when valbenazine is stopped, the tardive dyskinesia will go back to about where patients were at baseline. The long-term efficacy shows that patients have sustained improvement, much improved or very much improved for a large percentage of patients, and this treatment response is sustained throughout the 52 weeks of the study. For deutetrabenazine, we also have long-term data going out to 106 weeks. The data show suppression of tardive dyskinesia, which is sustained during the treatment time. A large percentage of patients are much improved or very much improved on the CGI and PGCI on this long-term treatment period. The key point is that there's evidence for efficacy of VMAT2 inhibitors for treating tardive dyskinesia. The evidence is increasing, and we now have long-term data on the efficacy. Now we'll go back to our patient K to consider VMAT2 inhibitor treatment. A point to consider here is a patient who's reluctant to use additional medication. Kay is our 52-year-old patient who's a cashier at a retail store and also a professional singer. She's had bipolar disorder for 20 years, takes carbamazepine, haloperidol, and a VMAT2 inhibitor, which was added to treat tardive dyskinesia. Her initial TD symptom was a spasm in the back of her neck, but then TD symptoms worsened to include lip puckering and jaw movements, which interfered with her quality of life and function. Carbamazepine and haloperidol were tapered, but the symptoms did not improve. The TD symptoms have now improved since a VMAT2 inhibitor was added, so now Kay wants to stop the VMAT2 inhibitor because she's tired of taking so much medication. So really, the information we can provide to Kay is that if someone has done well on a VMAT2 inhibitor, if their tardive dyskinesia has been suppressed, when they stop the VMAT2 inhibitor, they will likely go back to their baseline level of tardive dyskinesia. We have evidence on this from Valbenazine showing that the tardive dyskinesia symptoms will increase back up to baseline when the medication is withdrawn. Really, the treatment of patients with VMAT2 inhibitors for tardive dyskinesia involves shared decision-making and also continued monitoring. You want to reiterate that we want to assess these symptoms frequently, monitor them for change, and provide ongoing education for the patients that VMAT2 inhibitors are suppressing symptoms, but again, if they're stopped, the symptoms will likely increase back to baseline level before treatment. Key points to consider here are that discontinuation of VMAT2 inhibitor therapy may result in worsening of TD symptoms back to where they were before VMAT2 inhibitors were started. People with tardive dyskinesia require ongoing monitoring and ongoing discussions of the risks and benefits of VMAT2 inhibitors if these are initiated for treatment of tardive dyskinesia.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/EMM860. This activity is supported by an educational grant from Teva Pharmaceuticals. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer View Institute for Medical Education.